back to Nursing Analysis. Today, we will continue a pharmacology review on cardiac medications, and we will review calcium channel blockers during this lesson. So let's begin. Calcium is found in large amounts outside of our cells. Every cell membrane has channels that are specific to the electrolytes it allows to enter. So calcium enters through calcium channels. Remembering the rules of action potential from previous videos, we know once a cell is stimulated to take an action, certain channels open to allow electrolytes to enter, which changes the polarity inside the cell. Calcium enters L-type voltage-gated channels. These channels are located in vascular smooth muscle and also found in both the cardiac myocyte and cardiac nodal tissue. This includes the sinoatrial node, which is also known as the pacemaker of the heart, and the atrioventricular node. The entrance of calcium stimulates contraction of smooth muscle and cardiac muscle. Calcium is also heavily involved with electrical conductivity and impulse transmission. Calcium increases the force of the heart's contraction. It also impacts vascular smooth muscle contraction, which results in vasoconstriction, which in turn increases the blood pressure. So, what problems can the entrance of calcium into the vascular smooth muscle, cardiac myocyte, and nodal tissue cause? Let's start with the nodal tissue. If the electrical conduction speed is too fast, this can produce a tachydysrhythmia. As for the contraction of the vascular smooth muscle, this can result in vasoconstriction, which will increase the blood pressure and cardiac afterload, which is the amount of resistance the ventricles must overcome to contract. This results in a higher demand for oxygen. The cardiac myocyte stimulation causes the heart muscle to become aggressive, making the force of the contraction stronger, which again raises the need for oxygen supply. We will now discuss the use of calcium channel blockers in the treatment of these potentially dangerous conditions. Calcium channel blockers can reduce the contraction of the arteries, which causes vasodilation. This will lower the pressure of the blood and cause a negative inotropic effect on the heart as it reduces its afterload and decreases its contraction force. Calcium channel blockers work in the nodal tissue, specifically at the atrioventricular node. They slow the electrical conduction impulse, creating a negative dromotropic effect. Calcium channel blockers work on the cardiac myocytes, which slows the rate of contraction, producing a negative chronotropic effect. Calcium channel blockers are used to treat conditions such as hypertension, angina, and tachyarrhythmias. So, let's put it together now. Calcium channel blockers are used to treat hypertension by blocking the contraction of vascular smooth muscle, producing vasodilation and reduced afterload, which decreases blood pressure and the force of the heart's contraction. Secondly, calcium channel blockers treat angina, which is the medical term for chest pain, which is usually caused by the narrowing of vessels and decreased oxygen supply. Calcium channel blockers promote vasodilation and decrease the work of the heart muscle. These combined effects reduce the demand for oxygen. The third condition, tachyarrhythmia, can be treated by the calcium channel blocker's ability to reduce the firing rate of electrical impulses. Reducing this rate will prolong repolarization, also known as the resting recovery phases of action potential. So now that we know the effects of calcium and the counter effects of calcium channel blockers, it is important to understand there are 3 subclasses of calcium channel blockers, and each class brings different positive and negative qualities when used for treatment. The 3 subclasses are dihydropyridine, benzodiazepine, and phenylamines. Dihydropyridines are primarily used on smooth muscle. They reduce systemic vascular resistance and arterial pressure. They are used for the treatment of hypertension. They act quickly with a vasodilatory effect, which can produce a potentially dangerous adverse effect known as reflex tachycardia, which is an increase in oxygen demand. So this class should not be used for patients with angina. These medications usually end in dipine, like as in amlodipine, or nicardipine, or nifedipine, and nifedipine. The second subclass of calcium channel blockers is known as phenylamines. This class is used to treat angina. It produces vasodilation that is milder than what is caused by the dihydropyridines. So the consequence of reflex tachycardia is not as big of a concern with this subclass. This class concentrates more on the heart contraction, producing a negative inotropic effect on the heart. It is important to note this class of calcium channel blockers is contraindicated with combination beta blockers related to its negative inotropic effects. Medications in this subclass include verapamil, galapamil, and phenylamines. The third class of calcium channel blockers is known as benzodiazepine. Think of this class as a mixture of both of the other 2 classes mentioned. It works as a cardiodepressant and a vasodilator. It has a very mild vasodilatory effect, which, remember, decreases heart contractility force. This subclass should be used cautiously with beta blockers. This class includes diltalazine. We now must discuss adverse effects and nursing considerations, which are medication specific. We will start with nifedipine, which can cause reflex tachycardia. We must monitor for increased heart rate. A beta blocker, such as metoprolol, can be administered to counteract the tachycardia. Nifedipine can also cause peripheral edema, and we must observe for swelling and teach the patient to report this to the provider. A diuretic may be prescribed to control the edema. Acute toxicity with excessive doses can occur, so we must monitor the vital signs and obtain a baseline EKG, as well as future EKGs when problems are noted. Gastric lavage and cathartics may be indicated for severe toxicity. Norepinephrine, calcium, and isoproterenol Lidocaine and IV fluids may be needed. Keep cardioversion and cardiac pacer by the bedside. It is important to note consuming grapefruit juice and nifedipine can lead to toxicity. Verapamil and diltalazam can cause orthostatic hypotension and peripheral edema. We must monitor blood pressure, observe for swelling to detect edema, and perform daily weights. Teach the client about signs of postural hypotension, which include lightheadedness and dizziness. If this occurs, instruct them to sit or lie down. Constipation can be caused primarily specific to verapamil. Instruct the patient to increase fiber intake and oral fluids. It is important to mention when giving verapamil IV, we need to inject slowly over a period of 2 to 3 minutes. Verapamil can increase digoxin levels, increasing the risk of toxicity. Now, let's talk about common side effects to all calcium channel blockers. These include hypotension, headache, flushing, constipation, rashes, and photosensitivity. And now, it is time I'm sure you have been counting on. It is the Rhyme Time Review. Calcium is a member of the extracellular panel. It enters the cell through its own specific channel. Its presence is sequential for action potential. So through which well does calcium excel? We remember the voltage gates of type L. To begin this tussle, entering the vascular smooth muscle, it joins the fight inside the cardiac myocyte. During a simultaneous issue, it also enters the nodal tissue, concentrating on a certain traveled road that enters inside the atrioventricular node. When calcium enters, it causes a reaction which stimulates muscle contraction as it increases cardiac friction noted by the vessels, vasoconstriction. Conduction impulse will also increase as more calcium is to be released. Sometimes our bodies cannot take a stand to calcium's actions that cause a higher oxygen demand. So when we need to stop it, we must first block it, which brings us to our pharmacology topic. First on the scene is dihydropyridine. Its actions are fast, we must mention, as its uses include the treatment of hypertension. Reflex tachycardia is a concern. From the use of this class, we learn. I must also remind you, this class is not to be used to treat angina. Next on the scene, the second subclass, phenylamine. This is the choice to treat angina. Just put the last class behind you. It remains in place at its station, producing effects of vasodilation. Its actions are controlled and not wild, as its dilatory effects are very mild. It is in the business of relaxing, as it focuses its effects on the force of the heart's contraction. Since it is a good contraction stopper, we must not use it with a beta blocker. Now the third class, benzodiazepine. Its effects are recognized as in between. It is more of a lenient stopper and can be used with caution beside a beta blocker. Thank you for taking the time to learn with nursing analysis. I am looking forward to hearing from you in the comment section for any ideas or requests for future videos. As always, your support is greatly appreciated. Please continue to like, share, and subscribe to help us to continue to grow and provide educational videos.
Bored at work every day? Stuck in a dead-end job and going nowhere? Let us inspire you to get out of bed in the morning. Choose a career that's challenging and rewarding. Choose a career in nursing. And choose Medical Prep Institute to get you there. Come join those who have already embraced that inspiration by calling or emailing us today.